Sorry, I had some interruption, so this has been divided into two parts. Now, as far as the uh, management goes, when you get the patient, you suspect they have got pancreatitis. It's nice and simple. Always keep it easy. Stick to the ABCD, and I'm sure you know what the ABCD are. But the front lines, where the patient is in the emergency department, you need to put in an intravenous line and take some bloods at the same time and give them some pain relief. So that's just one-stop shop. And they will need some oxygenation if they are struggling, and hydration. So oxygen mask, IV fluid, put a urine catheter, and ask for the bloods, the routine bloods that we always do in any abdominal emergency, and these are a must, and no different from any other forms of abdominal pain, regardless of the cause. So full blood count, urinase, liver function test, lipase, CRP, and the pregnancy test in young women. Now, the type of fluid doesn't matter. A lot of people have investigated the role of variety, whether we give them crystalloids, such as normal saline, or Hartmann, or colloids. Doesn't seem to make a huge big difference. And we settled on the crystalloids in the last few years that because the patient will need a lot of fluid, we will eventually need some albumin to fill in the intravascular compartment. But the fluid is done in the emergency department with usually normal saline or Hartmann solution. We give them a stat dose, and that stat dose could vary between 200 and 500 mils. If they are well, they will pick up, and you don't need to worry about them too much if it is a mild attack of pancreatitis. But if it is severe, they will need a significant volume to fill their vascular compartment. And the reason for that is, if you have got severe acute pancreatitis, there will be a severe systemic inflammatory response. And that systemic inflammatory response means that the vascular bed in the entire body is going to be dilated, and it also will be leaky, which lead to extravasation of a huge amount of fluid and electrolytes into what we call the third space, which is the extracellular compartment of the body. And the amount that can be sequestrated in that could be tens of liters. Generally, if the patient is unwell and need more fluid, give them more fluid and more until you have done 2 or 3 liters before you start thinking sending them to the intensive care unit to have some vasopressors, because that will be the next step. Now, the immediate goals that you want to achieve, I think we mentioned part of that, but you mainly need to make sure that the patient is hemodynamically stable. How to ensure that? Blood pressure and heart rate. Mean arterial blood pressure over 70. That's what I prefer, and that will achieve adequate end organ perfusion to the vital organs, the heart, the kidneys, and the brain. Every patient with pancreatitis, unless you think it's really mild, will need a urine catheter, and monitoring their urine output is a great tool to know how well they are doing in terms of their hemodynamic stability. We generally want to see at least 20 mils of urine per hour for a patient who is, let's say, in their 50s or 60s, and they weigh 70 to 80 kilogram. If it is less than that, then they are depleted and they need more. And if they need more and they are not responding, then they need vasoconstrictors in the intensive care unit. Oxygenation is very important because with the systemic inflammatory response, you get respiratory failure and hypoxia, which will uh, affect the recovery really badly. Also, you need to ensure that you're actually not dealing with a different problem. You're not dealing with a perforated ulcer or another pathology that might not be pancreatitis. And with experience, you will know which one to guess that there might be something different. And the answer to that is simple. If you are on that, get a CT scan for them. And that will show us if there is a perforated organ or a ruptured aneurysm or ectopic pregnancy or severe diverticulitis, severe enterocolitis, whatever the cause that led to the pain and the rising lipids. We always need to address nutrition. Nutrition is a big thing in surgery and in medicine. And the nutrition, I will just remark on that with a few statements. Patients develop ileus, which involve the stomach and the small intestine, and they don't absorb, which means that we can put an nasogastric tube, and we usually in the first day or two monitor the output from the nasogastric tube. And we aim that within 2 to 3 days, their ileus will start to improve, and then we put a nasogastric tube and feed them that way in a low doses. And the low dose will be usually in the form of Ensure that runs at 10 or 20 mils per hour. If we don't achieve the caloric intake that they need, we will do a total parenteral nutrition, which hopefully we get to discuss in the future. A very important issue in pancreatitis is that we should assess the severity. And there are so many scores and processes that have been investigated to assess the severity. Now, we usually say mild, moderate to severe, 3 grades. The Ranson score is the oldest one, and Glasgow score as well is a bit modified Ranson. Both of them are cumbersome, and they take a lot of details to be able to calculate them. My opinion about them is that they are mostly academic, but you could do them for severe pancreatitis, and they rely on white cell count, CRP, urea, how much fluid the patient needs, their serum albumin, their liver function test, their oxygenation, and so on and so forth. Now, a very simple tool to assess the severity is the CRP. Now, there is no rigid line to define mild from moderate or moderate from severe pancreatitis. But anyone who's got CRP above 150 mean that they have got at least moderate pancreatitis. If they have got more than 200, it's usually severe pancreatitis. The other benefit of the CRP is the fact that we could measure it daily to measure the progress of the patient to see whether it's going up or going down, and that correlates really very well with the general condition of the patient and how they are progressing. Now, the other way we can assess their severity is the Balthazar criteria. And Balthazar is a radiologist who studied the severity of the pancreatitis based on CT scan finding. So if you've got mild pancreatitis, it's defined as inflammatory changes in the retroperitoneal tissue that's described by the radiologist as fat stranding. If you see free fluid in the peritoneal cavity, then that's moderate severity. Severe pancreatitis is characterized by pancreatic necrosis, and the CT scan with the intravenous contrast will show you whether there is necrotic tissue in the pancreas or not, and you need to see that to be able to recognize it for the future. And we'll try to show you some pictures in a different presentation, hopefully. And that Balthazar criteria is valid and a great tool and easily manageable. It doesn't mean that every patient who get pancreatitis will need to have a CT scan because, as we said, more about 50% of them they're caused by gallstones, and they're mild. They tend to settle within a day or two. You don't need to do anything to the mild apart from fluid and painkillers and rest. And then, if they have got gallstones, they remove their gallbladder within 4 to 6 weeks' time to reduce the risk of the recurrence. Complications are related to severe pancreatitis, and these can be in the form of multiple organ failure, and that's the first 10 days usually, and that's when the patient could die from pancreatitis. After 10 days, sepsis will be the enemy because the patient has got lines everywhere. They have got gut that's paralyzed with bacterial translocation, and they have dead tissue around the pancreas or the pancreas. Bacteria in general love dead tissue, so that can get infected easily. And if the sepsis mismanaged, then the patient could die. So with any sign of sepsis, with increasing temperature or increasing CRP, and the patient is not doing well on other fronts, low urine outputs, tachycardia, needing more support, mean that you take them to the CT scanner and you see if there is an infected collection. And the infected collection is defined by either free bubbles of gas in the fluid or enhancing wall. The radiologist should be able to recognize that early, and then we can drain them along with antibiotics. GI ulcerations are very important in any major illnesses. So these patients do not forget they will need to be on pantoprazole or Nexium to protect their gut. Also, I should mention they should be on subcut or subcutaneous DVT prophylaxis because they are ventilated and they are sick and they are high risk for thrombus formation. Bowel ischemia, usually as a result of injury to or digestion of a blood vessel by the pancreatitis process where it's severe, or as a result of hypovolemia and hypoperfusion, typically happen in the terminal ileum and the right column. Often their blood sugar will go up, so you need to manage their diabetes and keep their blood sugar at normal level as much as you can. Now, these patients with the severe pancreatitis, they are in the intensive care unit. So what are we doing for them? They've got a central line through which they have their medications, they have their fluid, and we measure their central venous pressure to help us to see how well they are filled. They get an arterial line to give us an ongoing monitoring of their mean arterial blood pressure, which should be achieved above 70, usually with the fluids and vasopressors. They will be ventilated because not only the respiratory failure that is associated with it, but also the fact that they get confused because of lack of oxygen going to the brain. And they will be difficult to control their airways and difficult to deal with as well in terms of their movement and behavior. Vasopressors, noradrenaline is the main vasopressor agent that we use in intensive care. There are other drugs. They do the same thing, but they might work on different receptors. Patients with severe necrotizing pancreatitis should always be on antibiotics, and if they are severely ill, we prefer meropenem, but ceftriaxone could probably do a comparable job. As a nutrition, we mentioned that, and that could be in the form of TPN. It usually is in those who've got multiple organ failure because they won't be absorbing from their gastrointestinal tract. Hemofiltration, because they're likely to become anuric with acute renal failure due to tubular necrosis. And if that happens, if the patient improve later on, things will start to improve and their kidney function will recover. It might take several weeks before it does, but it will. Now, the outcome of the patients, we need to know the outcome of the patients of severe cases. What else can happen to them? So we said as the death in this situation is bimodal. I emphasize that again. It's bimodal. First week or 10 days, it's multiple organ failure. After that, it's usually necrosis. So it goes like this. The management of acute pancreatitis, patients could die from either too much too early or too little too late. So we try to do the minimal in the first 2 weeks. No intervention unless there is septic focus that need to be drained. And during their course, there are patients who bled and died from arterial erosion. Unfortunately, this could happen to a major artery. It could erode into the splenic artery or the common hepatic artery or the superior mesenteric artery. And if that happened, it could be in the form of a false aneurysm. If they bled and stopped, and then the artery could be salvaged with an endovascular stent. But if they bleed enough, this might be the reason that will eventually kill the patients. Portal vein thrombosis and splenic vein thrombosis are relatively common in pancreatitis, and we don't do much about them apart from anticoagulation for 6 months. And some of them will develop pseudocyst. Now, hopefully that will give you an idea about the overall picture of acute pancreatitis, but there will be more lessons that we will try to cover variety of other things that are mentioned in this presentation.